this is part 5 of the high-risk newborn infant. So because of that lack of direct contact with the blood vessels and the alveoli, you have less gas exchange, plus you have immature alveoli, and you have lack of surfactant, all of which can prove to be problematic for the preterm infant and increase their likelihood of developing, or the risk of the baby developing, respiratory distress syndrome. You want to observe the baby for symptoms of respiratory distress syndrome, including cyanosis, tachypnea. They can have grunting, flaring, retractions, low respiratory rate. They can have grunting and nasal flaring. They can develop apneic spells, which we assess for them. And in addition to all of which we just said, the baby, because the baby's respiratory system is immature and preterm, they have a weak or absent cough reflex, so they're at greater risk for aspirating on their own secretions. So you're going to watch their SpO2 rates, and we're going to do some assessments to make sure that their respiratory rate is their pulse ox hopefully is above 95%. However, if they are having problems, you may see it drop, and they may want them on continuous monitoring. There's some indicators about a baby's respiratory stability. Look at this baby's color, and how pale this baby's color is centrally. The baby's color tells you a lot about the baby's cardiopulmonary status. Preterm babies can also develop plethora, which is this deep rosy red color. It's more common in babies that have polycythemia, but it can also be seen in babies who are over-oxygenated or overheated. So we're going to observe them, because we're going to be doing all of these interventions with them to try to prevent problems, but we don't want them to become over-oxygenated or overheated as well. And you can best see plethora when you put the baby next to a baby who has a normal color. The baby on the right has a normal coloring, and the baby on the left has plethora. So you can really see that deep rosy red color. So you have an increased risk of that as well. Babies have an increased risk of, if they're in respiratory distress or having poor cardiopulmonary function, they can become cyanotic, and you can see the kind of ashen gray color to this baby. And this is a baby with ethnicity, and I get this question a lot with babies who have ethnicity. Can you see the cyanosis? And you definitely can see it, and you can see it in this baby. This baby does not have the nice pink color that you would expect this baby to have. The baby has more of an ashen gray or blue color. We talked about this in the normal newborn assessment, but it's not common to see, but it's more frequently seen in preterm babies, and that's the Harlequin sign, and it has to do with the immaturity of their vascular system. So some of the respiratory interventions that we're going to be doing with these babies, they may need rescue surfactant therapy. Your textbook talks about that. I don't have a whole lot of time to get into that, but you may see that being put into place. You might see the nurses and the healthcare team using or monitoring their pulse ox. So they'll put a device on the baby's foot or on the baby's hand to monitor their pulse ox. And we're going to assess apical pulse and respirations. They may give the baby blow-by O2 at delivery, or they may have more long-term needs for oxygen instead of the short-term, but you may see them use O2 delivering systems. This baby has persistent cyanosis, and you can really see it in this kiddo. So we're going to assess for that, and we may have interventions based on what we see. I talked to you guys about Silverman-Anderson's assessment scoring for for respiratory distress in the normal newborn, and I told you we would get back to it in high risk, and so now guess what? We're back to it because we're in the high risk content. It's very similar to how I taught you how we assess. We have criteria and then we assess them and give them a score just like we did APGAR, but the difference in this is the higher the score, the more in respiratory distress your baby is. So a score of 0 to 3, your baby does not really have respiratory distress syndrome. A score of 4 to 6, baby has symptoms of moderate respiratory distress syndrome. Score of 7 to 10, the baby has severe respiratory distress syndrome. These are 2 links that might help you if you need to see a baby that's in respiratory distress and what it looks like, and here's link 2. Babies can have retractions, which is the visible sinking of the soft tissues around the chest, between and around the ribs, and the cartilage around their ribs. And it a lot of times begins in the intercostal spaces, but you can have mild retractions and you can have moderate to severe retractions. And this is a very pronounced retraction you can see, and it's really a symptom of labored breathing. It's telling you your baby is really working at the workload of breathing is very hard for your baby, and your baby has labored breathing. You can also assess either through your stethoscope, or you can actually hear it sometimes audibly just standing next to the baby's you can hear grunting, and it's this abnormal short deep hoarse sound, almost like, to me sometimes like they're humming, but it occurs because the glottis briefly stops the flow of air, halting the movement of the lungs and their surrounding structures. And in newborn babies, whether they're preterm or term, atelectasis can cause grunting. So you're going to want to become familiar with learning how to work with respiratory equipment. I already talked to you about the pulse ox, but some of the other things we're going to be doing: maintaining a patent airway, administering O2, monitoring their O2, monitoring their heart rate and their respiratory rate. You want to become comfortable working with the respiratory equipment. A lot of times in the NICU environment, you will find yourself working with the respiratory therapist, but you also too want to become familiar with equipment, because the respiratory therapist may not be right at the bedside and your baby needs something that which is in your scope of practice to adjust, and you will. So you want to become comfortable with working with the respiratory equipment. You want to become comfortable positioning the infant, and I'll show you how we position them for their respiratory needs. We're going to look at suctioning the baby and performing chest physiotherapy. So, chest physiotherapy is done to break up or make those secretions that are in their lungs more mobile, to move those secretions. And so they may have devices that are used to do this. They may be very small and give very small vibrations that you will then apply to the baby's chest in different areas of the baby's chest. They also can do it if the baby's intubated by using pressures, the pressure setting and the pressures on the vent. But we may have to do chest physiotherapy to help those secretions become more mobile. You want to become comfortable with working with babies who are on the ventilator, so working with ventilators and what the settings mean, and assessing and recording the assessments. The setting findings will be part of your assessments. Some babies don't necessarily need to be completely intubated. They may just need some CPAP, which is continuous airway pressure, to help keep the alveoli open and improve chest expansion. So becoming comfortable working with babies who are receiving CPAP. Some babies just need extra O2 in their environment, not necessarily CPAP, or they may not necessarily need to be vented. They may just need extra O2, a higher concentration of O2 in their environment. So they may put the baby under oxygen hood. You are going to work in a collaborative setting with respiratory therapists and other members of the healthcare team to manage and maintain and meet the baby's respiratory needs. Some babies don't necessarily need CPAP or intubation. They may just need a little bit more O2 delivered to them. So they may need O2 by nasal cannula, which you probably have become very familiar with and administering care to your older patients. So we may have to regulate their oxygen needs via nasal cannula. And just like in peds, you learned about weaning babies off of O2. We will wean babies in the NICU environment. We'll slowly over days to hours or whatever, decrease the O2 that's being administered to them. So these are all 4 pictures showing you all the 4 types of ways that respiratory equipment. They're not just limited to this, but these are just some examples that we just talked about. So the nasal cannula, the CPAP, intubation, and the oxygen hood. I told you that preterm babies are at increased risk for developing a condition called apnea in the neonate, where they have these periodic apneic spells, and it is associated with prematurity and bradycardia. So some babies have to go home on an apnea monitor. There are different ways we can treat this as well. They may give the baby extra O2. They may be on an apnea monitor, give them stimulants, put them on CPAP, and we can also give them meds. I know you don't believe this, but we can give caffeine IV, and that's one of the things that we'll do with babies that may have this problem. So we may try a medication approach in conjunction with the other interventions that we are implementing. We are going to use different positioning techniques in the NICU environment. This is very different from the normal newborn nursery. And what I'm saying to you is limited to the newborn nursery. So we are going to use positioning to help facilitate drainage. Babies need to be moved every 2 hours, just like the adult, because they are at increased risk for skin breakdown as well. But we want to move those respiratory and secretions and facilitate drainage of those secretions. So we may use a side-lying position, and this baby's in a side-lying position with a containment pillow. We may put them in the prone position. Now, I know that in the normal newborn nursery and information, I stressed to you that we want babies laying on their backs with nothing in their crib and their environment, and that is true in the normal newborn nursery environment. But then the NICU environment, first of all, you're going to have the baby on one-to-one care. Second, because of their needs, we may have to use other positions to help them meet their respiratory needs. And this is an example of this. The prone position is not recommended for term newborn babies and babies in the home environment, but in NICU, we use this position because it makes the workload of breathing easier for them. It allows them to use more of their accessory muscles to breathe, and it decreases the respiratory effort. We can use the supine position, but even in using the supine position, we're going to move them every 2 hours, change their positions. We may use rolled blankets, towels, and washcloths to support their different extremities, and sometimes we will use a containment pillow. Suction equipment must be available at all times, and you're going to check your equipment at the beginning of each shift to make sure that your equipment is functioning and that you have all equipment that you need. A bulb syringe may appear less traumatic to you, but it may not be able to reach those secretions that are deeper in the baby's airway, and so you may have to have the baby suctioned, or you may engage in suctioning interventions to clear those respiratory secretions for your baby. You want to maintain hydration. Now, this is something that would be ordered. It's not something that we do routinely, but sometimes they may want a little bit of saline. It's just a tiny amount, like even less than half of a, maybe half a cc or something, that may be added to the endotracheal tube and then suctioned out to help then sometimes those secretions that have to be moved. We're now moving to problems with thermoregulation. Preterm babies, definitely we have issues with adapting to and meeting their own and holding their own body temperature. We talked about that in the normal newborn baby. But you're going to assess them, assess their color, we're going to record their vital signs more frequently in the NICU environment. They may have inadequate heat thermoregulatory systems within their body. You might see decreased decreased muscle tone, poor feeding, lethargy, irritability. To touch them, their skin may be cool to touch, and they may have more mottled skin. So it's critical to remember that thermoregulation issues are very important for your preterm baby. Your term baby has issues. Your preterm baby doesn't have brown fat. They don't have the reservoirs that your term baby has to rely on, and they can go into cold stress very, very quickly.